who are a digitally enabled quality assurance company. We're going to be joined by Professor Jane Cummings, who's the former Chief Nursing Officer at NHS England and is working with Tenderble. And we're also going to be joined with Andy McGovern. And they're going to be talking about some of the great work that they've been doing with Kettering General Hospital and some of the other examples about improving quality assurance in the NHS. Look forward to the session.
Hello and welcome. Thank you for joining us for this session. We have 20 minutes to talk to you about digitally enabled quality assurance, and I'm delighted to be joined here by Jane and Andy, who I'll let introduce themselves briefly, and also my colleague Joel as well, and we're from Tenderble. Jane, do you want to maybe introduce yourself and help us set the scene for this conversation? Thanks.
So good afternoon, everybody. My name is Jane Cummings, and in case you're wondering, I am actually the same person that was on the photograph. But we've taken it down because it's slightly embarrassing, because that photograph was about 15 to 16 years ago. And before any of you say, I know I've aged quite a lot. So I'm one of the advisors to Tenderble, but I'm also a non-executive director, vice chair of an integrated care board. As I think you've already heard previously, Chief Nursing Officer for England, Regional Director for London, and a variety of other jobs in the NHS, where I've been for probably more years than I care to remember. Thank you.
Good afternoon, everyone. My name's Andy McGovern, and I'm Associate Chief Nurse at Kettering General Hospital. I've been there for 4 years. I spent 20 years prior to that working in London. So when Jane was Chief Nurse in London, I was a member of staff down in London. I've been involved with using Tenderble almost since it was launched as a product back in 2016. 2016. I think the organisation I was working for in London adopted it in 2017. So I had wide experience at Tenderble. Okay.
Jane, I think we're going to kick off with a question for you based on your time and role at Gloucestershire ICB. Could you tell us a bit about the role of ICBs in ensuring quality in the healthcare service?
Yes, I will. And there's been quite a lot of talk about the role of integrated care boards in England recently, particularly. From my perspective, the role of an integrated care board is really to have an overview of quality across the system. And that can vary depending on the size of them. Some of them are small and, in our case, perfectly formed. Others are very, very large and a bit like the old health authorities used to be. I think there's also a really important need to look at assurance, and that is predominantly as a result of a lot of the investigations and problems that we've seen with lots of investigations into failings in quality, which you will all be well aware of. We've got a responsibility to assess and manage risk, and the identification and management of system risk is actually quite difficult to do. This is not about single organisations, it's about the whole system. And I think the other key role for ICBs is to deliver on the 4 key aims of ICBs, and some of you will know what those are, but if I just highlight a couple of them, one of them is about improving outcomes, both in the population that we're there to serve. So population health and health outcomes, absolutely fundamental role for an integrated care board, as is tackling inequalities. And that's inequalities in both access, it's inequalities in experience, and it's also inequalities in outcomes. And again, it's very well rehearsed, the inequalities that we see across the system. And then the third is around enhancing productivity and value for money. And you can't fail to have noticed the amount of noise or commentary, focus there is on productivity. We have seen a significant increase in the numbers of staff. Most of you, if any of you work in frontline services, you'll say we still don't have enough and we're under a lot of pressure. But actually the way we look at how many staff we've got, how much money we spend and how much care we can deliver has changed quite a lot. And so something about how we look at productivity and how we enhance productivity is really important. And then the final one for ICBs is how we support the NHS to look at our broader social and economic development role. And actually, if you're looking at population health, it's much more than the NHS. It really is around education, jobs, housing. And as part of an integrated care system where you work in partnership with everybody, you have a responsibility and a role to look at that wider impact and how the NHS can support that wider work. We have statutory responsibilities for making sure we set up system quality groups, system quality committees. I chair a system quality committee. And one of the things that if I'm honest, I've struggled with, and lots of people have struggled with, is how you balance the role of an integrated care system with the role of individual providers who, as sovereign organisations, are accountable for the quality of care they give. And you have to do this in partnership. It's not about pure performance management or pure oversight. It's really about how you do it in partnership. One of the other risks I think we've got is the volume of data. We get, and providers in particular, often have masses of data. And again, many of you who will have looked at some of the quite well-known individuals around will say, how do you look at, so Bill Kirkup said in the East Kent report, how do you find the signals amongst all the noise? Aidan Fowler, the National Director for Patient Safety, has said, how do you find the red flags in multiple sets of data? And then somebody called Steve Black, who's a really good analyst, who actually does also write for the HSJ, said, how do you filter and display the information at the right level and in the right volume so that rather than overloading people with information, you can really identify the things that need your attention. And we all know that that's actually really difficult to do. So that's some of where I think we are. I've got more I will say, but I'll stop for the time being. Otherwise, I'll talk for 20 minutes and you'll never hear from Andy, which is much more interesting.
Brilliant. Thank you for that, Jane. And yeah, now on to Andy. Maybe, Andy, tell us a little bit about Kettering, how you've been able to tackle some of the quality challenges that you face and then enact some really meaningful quality improvement.
Yes, so I lead a team who support assurance and delivery of clinical care in relation to tissue viability, falls, and sepsis, and something else as well, nutrition, hydration. And I think one of the key things is that these are all absolutely linked together. And, for example, good nutrition, hydration absolutely has an impact on the reduction in harm from pressure ulcers. It certainly ensures that patients are less unstable and helps to avoid falling down. So one of the things that we've done is, in bringing the team together, is that we're able to focus quite clearly on how they triangulate together. And I think there's something really, really important about triangulating the data. It isn't just about the quality data in terms of your processes. We measure that through Tendable, and that gives us really, really valuable data. But we also link that to our outcomes. So we use Datix for our incident reporting, and we're constantly looking at the data. I call it constant vigilance. So we're always looking at how many falls, pressure ulcers, incidents related to nutrition, hydration are occurring on the wards, but linking that to the results that we're getting through our process audits that we do through Tendable. And that enables us, if we see an increase in harm from pressure ulcers, for example, we'll go back and we'll look in more detail at the results from their Tendable audits and see if there's a link and see if there are any particular processes where they are identifying a problem. And we review this data. We've not got to daily yet. We've not got it in real time, but we are looking at that every single week. And we have a Friday morning meeting religiously at 8 o'clock. It doesn't matter what day it is unless it's Good Friday, because I'm not there on Good Friday. And a lot of other people are as well. But every Friday morning, 8 o'clock, we look at that data, we look at it at ward level, we look at it at divisional level, and we look at it at organisational level. And to give you an example of improvements that we've made, 2 years ago we were getting probably 8 pressure ulcers per month, categories 2 to 4. We've now reduced that down to 3 per month on average. Some months a bit more, some months less. Sometimes we've had 2. We've not quite got to 0 in a month yet, but that's a work in progress. But to add to that, we've not had a category 3 or 4 pressure ulcer for nearly 3 years. And our unstageable pressure ulcers, we used to get one every 2 weeks. We now get one about every 56 to 60 days. We've had 2 this year, in fact, so that's probably larger gaps than 56 days. So we've made some really impressive improvements in care for patients. And I think it's really important to recognise that if you're thinking about a measure of quality nursing care, there is nothing better than reducing your harm from pressure ulcers, because it demands really high quality nursing care in order to deliver it. So we're really proud of our results. It's not been done in isolation with just Tendible data. We've triangulated that data with staffing data, with our incident data, and as I say, every Friday morning we get together, we look at that data, and we try to elicit what's going on. And if we see a problem with an award, we put together an improvement plan immediately and address that. And consequently, we've seen that improvement.
I mean, that's really great outcome that you've had. And I believe you did that through implementing a specific pressure ulcer audit. Is that right, that your nursing staff used?
Yes, so we developed not just a pressure ulcer audit, falls audit and a nutrition hydration audit. And in Tendible, you can set up audits to be done at various frequencies. What we chose to do was, I suppose, something that recognised wards that improved. So if you a ward that scored 70% or less, which shows up as red on Tendible, we audit those wards every month. But if it's amber, we audit them every 2 months, and the green wards only get audited every 3 months, with the caveat that if we start to see other parameters where we're concerned, we will increase the frequency of the audits. In fact, we'll increase, and once we introduce a quality improvement programme, likewise, we will increase the frequency of the audits, because what we're looking for is to use those audits to demonstrate that we're seeing the improvements that we want to see.
Thank you, Andy. Jane, coming to you next, I was struck by your comment about the sheer volume of data that ICBs get swamped with. How do you make sense of that, and what do you think is the role of technology in helping to make sense of that noise?
So I think one of the risks is that we often get data that is historical, retrospective. It's measuring what's happened. And if you talking to international experts around quality improvement, quality assurance, we need to move to starting to predict. So using data to predict where problems are likely to happen. And I think using technology rather than the sort of handheld paper-based audit is actually really critical for that. One of the positives about using technology and things like Tendible is that it's in real time. So you actually, you're undertaking an audit. It's being uploaded immediately. You're getting you get that information very, very quickly, which means not only can you react in relatively real time, but you can also look at what you're collecting. So one of the things that Bill Kirkup said was, as well as how do you identify, where those signals are. So that is around having outcome measures that are meaningful, that are reliable, that are timely. If you're designing what you're going to put through technology, then you can actually make sure that you're deliberately planning to look at things that are timely, that are meaningful, that are based on outcome measures, and that you can add into that some of the risk adjustment that you might need to make. He also said you need to look at trends and comparators. And again, because something like Tendible allows you to compare, it could be service to service, it could be ward to ward, it can be hospital to hospital, it can be, in multiple different ways that you can look at and compare. You can start to see trends and you can start to predict where things are going wrong. Most of us that have been in the NHS for a long time, and hands up, I've been around for 45 years in the NHS. Now you can all work out how old I am. Actually, you know, that saying where you can walk into a service, or you can walk onto a ward, or you can walk into an emergency department, and very quickly you get a sense about how it is and what it is and how well it's doing. If you talk to your patients and your staff, you very quickly get to know when things are going well, when things aren't. Looking at a national patient survey once a year is too late. Looking at time, looking at things in real time are when you start to pick that up. And actually, technology is a really good way of doing that. It's also a really good way of helping with improvement. So we talked a bit earlier about, well, I talked about earlier about productivity. There is nothing worse than having clinical staff or any member of our staff who spends a considerable amount of time walking around with a clipboard, writing, you know, making manual audits, and then somebody sitting and inputting into a spreadsheet, and then sending to a BI team to churn it into graphs. If that is all done automatically, you save a considerable amount of time, which then can get refocused on direct patient care or the sorts of things that are really meaningful. And I know we did an audit in Tendable, and I think we found that we saved about 60% of time in auditing tasks by using technology, and about 80%, up to 80% of time in reporting. So that time is time that you can then put back in. You can use your time more effectively. And productivity is not about working harder. Productivity is about eradicating the time that you spend doing unnecessary tasks or futile working. It's about improving outcomes. It's about reducing harm. And if you can use technology to be able to identify the issues, reduce harm, you have improved length of stay, you have improved outcomes for your patients, and whether that be in a hospital setting or in a community. And all of those things mean that you could see more people, you can treat more people, you become more productive, but you're not necessarily working harder, you're just working smarter. And at the end of the day, what are we all here for? We're here to improve outcomes. We're here to improve inequalities. And if technology can help with that, then I'm all for it. So I think that's, for me, would be some of the most important things that actually sit behind using technology to really look at the quality of care we give, assure ourselves that we're doing the right care, and if we're not, taking action very quickly and then showing the impact. And I think that's what Tendable can also do. Of course, there are clearly other, I will say that, even though I'm an advisor to Tendable, but there are others. But it's about showing that you're taking action and that you can improve, and you're improving care. At the end of the day, that's what most people work in the NHS and social care to do.
I mean, some really brilliant points there, Jane. Andy, coming to you, I know we've talked a lot about the impact on patient outcomes in the reduction in the falls and pressure ulcers and things like that we were talking about just now. I don't know if in your experience with using a digital solution like Tendable, have you also been able to experience some of those efficiency gains in your processes happening more quickly because they're digital, like with the data flowing through in real time? Has that impacted your processes as well?
Oh, absolutely, yeah. When I first started, we had the massive Excel spreadsheet and going around with a clipboard and a piece of paper to tick boxes with a set of questions. And as Jane's alluded to, you'd get the piece of paper, you put the ticks on it, you pass it to an admin team, and 2 weeks later they inputted it into Excel. And then 3 weeks later, the BI team have done their bit and produced all these pretty graphs. And 4 months later, you're actually looking at the things that you did 4 months ago that you should have been improving in the 4 months ago. Whereas with Tendable and the way we do things, as I talked about the Friday meetings, we're looking at this data as close as possible to real time as we can at this moment. My ambition is to take the data from outcomes processes and the balancing measures that we gather and have them all in a single dashboard. We're not quite there yet at Kettering, but it's a work in progress. But we've got the tools to do it, and we will do it. It'll take a little while, and we'll get even more efficient. But the productivity levels that we've improved in terms of collecting data are absolutely huge, from 4 months down to 1 week. I think it's a pretty good improvement in terms of identifying stuff.
Definitely.
Andy, I just wanted to pick up on the impact that this has on staff. It sounds like clearly there is a lot of productivity gains to be had. You've had many, going from 4 months down to a week sounds amazing. But actually, what difference has this made to the day-to-day life of your staff? And how do you use tools like Tenable to actually celebrate them and their achievements?
So I think stuff like using tools like Tenable, I think people actually get excited about getting their results in real time. So I think that's made a real difference. But building on that, the fact that we've been able to achieve reductions in harm, we go out and celebrate it with monotonous regularity. I make no apologies for going out probably every week to 10 days and being able to take something like a hamper or a box of chocolates. Nursing staff in particular like chocolates for some reason. I don't know why, but they do. And being able to reward them, to recognise the success that they've achieved is just really, really great. And I feel really proud going out there and getting the photographs, and they're going into the Facebook page, and staff across the organisation, across the ICB are getting that. And and they are seeing that the staff are happy, patients are getting happier. And even in these challenging times, we're still maintaining these results, and staff are feeling happy about it. So I think it's a win-win.
I completely agree with that. And too often when you look at, things get lost, you know, individual members of staff or individual wards or individual services in the community, mental health, acute, primary care, wherever it might be, just get lost. Whereas if you are having real-time data that you can look at really quickly, that you can see the improvement and you can demonstrate it and you can show it, actually saying thank you and actually asking people to share what they've done really helps. And we often use, and lots of organisations that I've spoken to also use Tenable for accreditation. So they use it to support their ward accreditation or their service accreditation. And that again means that they can be really proud of what they've done and demonstrate that they are actually delivering a really good service despite all the pressures and despite the demands that everybody working in health and social care at the moment is facing.
I think we'll take any questions from either any of the audience here. I don't got any question for either Jane or for Andy about anything we've talked about. Yes, there's some hands at the back there. No, that wasn't a question. Okay. There's a hand at the back. Okay, yes, yeah. I don't know if we have a microphone for you. Come up here. Come up here. Have this one.
I wasn't expecting that. I'll come and sit here.
Thank you so much. It's exciting to hear how empowered the staff are obviously feeling about this. And I'm a Chief Nursing Information Officer, so interested in the design of our systems and whether they work for the people who use them. It sounds like this does. But do you kind of use feedback from users of Tenable to develop the system and improve it even more so that people feel like, how configurable is it for individual organisations, I suppose?
Happy to take that. Yeah, so absolutely is the answer. So we design with our sister partners. We work with a range of providers, big and small, from the private sector, from the NHS, and you know, every single thing that's on there is customizable. It fits with the organisation and actually is tested with end users, with our frontline staff, and you know, the questions have to work for them. The way they collect evidence has to work for them and fit with their work schedules. Otherwise, it just doesn't make sense. So it's a really important question, and it's at the heart of what we do.
It's really true. I mean, I've worked with Tenable off and on for for a few years. And one of the things, we've held several sessions where people have said it'd be great if, and the team have actually changed it. They've designed it around them. They've created the audits. They've created the sort of BI results, which have been specifically matched to individual service users and end results. So it really is a very flexible and responsive service, I think, which is vital because, you don't want to repeat work just for the sake of it, because if you've got somebody else in another part of the country that is doing what you want, pinch with pride. But if they haven't and you need to do something, then actually being able to work with Tenable to design it yourself is really important.
I can safely say that in the 8 years I've been using Tenable across two organisations, I don't think there's been any audit that we put together that hasn't been designed by frontline staff. It's their contributions that make the difference because they're the ones who know what we should be measuring.
Any more questions from the audience?
I'll be the roving one.
Immediately behind you.
I think I just wanted to ask more if you're using the system over an EPR system? So is there anywhere using it that would have it on top of their EPR system to pull out the data?
So again, we have a range of customers, and they all have slightly different setups. But we have APIs to be able to read data into Tendible and data from Tendible into other systems. So we have plenty of our customers that use tools like Power BI, and clearly they have their own API systems as well. And what we want is the data to be able to flow. But we really focus on the experience that we give providers in terms of quality. So what people come to us for is that quality-specific dashboard analytic reporting that your EPR system will struggle to compete with. But the data is free to flow from one data warehouse into another, and we are there to support that journey. Any more questions? I think I'll hand over to you, Joe, for the... Great.
Thank you. Thank you so much for your questions. Just before I hand over to Jane for our closing remarks, I thought I'd just quickly announce that we're on stand F8 downstairs. If you found this interesting, you'd like to find out more about Tendible, find a time to schedule a demo to see if it is something that's appropriate for your organization. And without further ado, then I'll hand over to Jane, who can finish us off.
I won't keep you long, promise. So I suppose, what do I want to say as closing? One is that I think quality and quality of care is probably the fundamental thing that everybody that works in the system needs to focus on. It's everybody's business. It's not just the business of nurses, doctors, and therapists. It is everybody's business. We also know, and the evidence is really clear, that good quality care saves money. It doesn't cost money, it saves money. It improves outcomes, it reduces lengths of stay, it reduces harm, and therefore you do end up with staff that often feel more satisfied because they're giving good care, that patients are more satisfied, they have a better experience and better outcome. Now that all sounds very, anybody could have written that, couldn't they? But fundamentally it's true. And actually when you look at the organisations that provide really good quality care or services that provide good quality care, they often are in much more financial balance, they have better outcomes, and actually they have much stronger and positive staff and patient experience. In order to do that in the best possible way, using technology saves time, it improves real-time data, and it supports you in your ability to predict and to look forward and to think that organisation or that ward or that service looks like it's getting into trouble. What can we do now to prevent something bad happening? And at the end of the day, that's what we're all here for. And as I can see from Liam, we are now at 21 minutes past 4, and we're a minute over. So thank you very much for being here. And I hope you found at least some of what we've said interesting. Thank you very much.
Thank you.